line, we have David Stoker. He is the executive director of a nonprofit, Better Life and Recovery, and co-founder of the Springfield Recovery and Community Center. We also have Robert Riley II. He's an addiction counselor at Clayton Behavioral and owns and operates 5 recovery houses in St. Louis. And so with that, I'm going to turn it over to our speakers today.
Great. Thank you, Emily. Good morning, everybody. The title of this presentation is Two Modalities with One Mission, Integrating the 12-Step Community and Medication for Addiction Treatment. The purpose of this presentation was to show how the two can work together, how we can pull all tools in and provide more resources for individuals with opioid use disorder. All right, let's get started. David, do you have anything you want to add there?
Yeah, I would just say, you know, as far as this presentation, I feel it's really important because there are multiple pathways to recovery, and I think the more pathways that we can get clicking together, the better opportunities we have to help people find and sustain recovery.
Great. So on our first slide, of course, we all know what the problem is. We know that the numbers are increasing every year. Off on the right, you'll see that the peak of the gun deaths was right around 1993 when we did receive some legislation regulating gun sales. The peak of the HIV was right around 1995 when medications were really starting to be introduced more heavily into the HIV population. Peak car crashes are on there, and that's interesting, 1972, because that's right around the time that we had legislation to mandate seatbelts be placed in all cars. So those are some interesting things. Next slide. All right, here's some of the other information. Talking about the different substances out there right now, we can see that fentanyl and the fentanyl analogs are skyrocketing right now, and that's our greatest concern. There's 32 analogs out there. We can only currently test for about 22 or 23 of them. I know in the St. Louis region, and David can share about his region, but in the St. Louis region, what we're hearing from our using community is that they can't even find heroin right now, that it's all fentanyl. And so that's why with our drug supply being poisoned the way it is right now with fentanyl, we're seeing the numbers still go up, even though we're having greater access and resources providing naloxone in the state of Missouri. It's directly related to the amount of fentanyl that is that's being seen in the drug supply. David, do you have any reports about? I know you had recent. Yeah, go ahead.
I can kind of piggyback on that. We just had a huge spike in overdoses where we had in 5 days what we normally have in a month, and a lot of that. I mean, we're still waiting on stuff to come back, but it's believed to be fentanyl. We also had people who had bought what they were told was methamphetamine that ended up having respiratory distress and then being revived after being Narcan. So it sounds like that fentanyl found its way into the supply of methamphetamine here too, which is super scary because you have a lot of people that are opioid naive if they're just meth users.
Yeah. And we're seeing the same thing in here on the eastern part of the state. You know, we're trying to organize better education within the using community and in the recovery community for those people that return to use, that maybe they're not going back to an opioid, that they are going out and buying maybe cocaine or methamphetamine, but because of the cross-contamination, it's not exactly a sterile environment that the drug dealers are weighing up or packaging the substances in, that's where we're seeing the cross-contamination and how it's ending up in other supply chains. So it's really important that we start educating not just the using community, but the individuals that we're working with as a whole. All right, next slide. So this graph is really intended to demonstrate how during the AIDS epidemic, which we're seeing a lot of correlations, how in 1991 to 2 we started to see a plateau, and if you remember on the first slide, in 93 is really when it started to drop. That's when we made the introduction of highly active antiretroviral therapy. It was really introduced and pushed out there, and that's when we see the numbers start to decrease. We experience some of that. It is regional in our region. I know that we've seen a growth in some of the accidental overdoses, but as a whole, once we start introducing medications into the community, getting more people on methadone, on buprenorphine, that's how we're going to see the drop. And so we're really trying to follow a lot of the data that we gained from the AIDS crisis back in the 90s, and follow the same type of system of care that they used by making the medications, removing barriers to the medications and making it more readily available. As of March, this is a little bit older, but facilities that are providing addiction treatment, only 82% of them were outpatient. 20, if you can go back to the other slide, David.
Oh.
21%, only 21% of those provided medication-assisted treatment with the use of methadone or buprenorphine maintenance. Okay, David?
So what we wanted to look at was a while back, they did a type 2 diabetes study. It was called Look Ahead, or the Action for Health and Diabetes trial, and they had over 5,000 people in it. And we thought that it's a good disease to look at next to addiction because of the commonalities. Like type 2 diabetes and substance use disorders are both heritable. So there's also a genetic vulnerability activated by environmental exposure, basically meaning that there's genetic cues and environmental cues. It's progressive. It gets worse. The longer you have it, the longer you keep it untreated. Also, both of them are often managed with medication and lifestyle change. Full or partial remission is also often followed by flare-ups and the need for additional treatment, or what we would call recurrences of use. And sustained uncomplicated remission is the exception, not the rule, meaning that people do get better, but for people to get better the very first time they try and never have a recurrence or a flare-up is very, very rare. And this right here, the next slide just kind of has the name of the study itself if you wanted to look up the study. So basically, the study had people who had type 2 diabetes, and they said, you know what, we want to introduce some things so that we can reduce the risk of cardiovascular disease, the risk of high glycemic or low glycemic instances, and look at losing weight and getting more fit. So what they said was they introduced that to people, and they said, you know what, we're going to give you the opportunity to do an intensive lifestyle change. And 3% of the people that were involved in the study without the intensive lifestyle change actually were able to make the changes needed to highly reduce their risk of cardiovascular disease. They were able to lose weight. They were able to get at a better fitness level and able to stabilize their sugar count. Now, with the intensive lifestyle change intervention, what they found was about 11% of the people were able to make those changes that were needed, which sounds amazing, right? And I would be willing to bet if we were to sit there and talk to those 11% of people in the study and say, hey, if you find out if you have type 2 diabetes and you do an intensive lifestyle change where you're going to support meetings and possibly meeting with a counselor and a fitness coach, are you going to need to go on medication, or are you going to be able to stabilize a lot of those problems on your own with the intensive lifestyle intervention? And they would probably say, well, why would somebody need to go on medication? All you need to do is do the exact same things we did. We call this anecdotal knowledge. Basically, it worked for me, so because it worked for me, obviously it's going to work for everybody else. The problem with that is that's only 14% of the people that were in the study. So of those over 5,000 people, less than 1,000 of them were able to use the intensive lifestyle change intervention to get off medication and create through that lifestyle change. That means that we had 86% of the people in the study that still needed medication in order to manage their diabetes and reduce their risk of cardiovascular disease. The problem, like I said, it's because of the anecdotal quality that a lot of us have. We believe, honestly, it works if you work it, right? Because it worked for me. So all you have to do is exactly what I do. I always say it amazes me how many people I know that work a program of humility that feel that their way is the only way. And I would put that out, I would put that out towards a lot of people in recovery. You know, I know people that found recovery through church and they feel church is the only way. I know people that found recovery through 12-step. They feel 12-step is the only way. People that found recovery through treatment and they feel treatment is the only way. And the truth is, it might work if I work it for me, but that doesn't mean that it's going to work if somebody else works it, because it might not be the pathway that's going to be effective for them. So with 12-step programs, we have a group of people. And I think I'll tell a little story here about what kind of changed my feelings on medication. I remember it was years ago, probably 6, 7, 8 years ago, that my treatment court judge came to us. I was a therapist at the time, and said we're going to have to start allowing people on medication into treatment court. And at the time, I was an abstinence-only person, and that's all I believed that was effective. And I was flabbergasted. I was like, really? We're going to give people a drug to get them off a drug? This is the stupidest thing I've ever heard. And I ended up going to one of my friends who had a couple more years in recovery than I did and complaining to him. You know, I walked in, I talked to him, and I'm like, I can't believe that they want us to give people a drug to get them off a drug. Everybody needs to get into recovery the same way we did. And he looked at me and he's like, what do you mean we did? And I said, well, everybody just needs to stop using drugs. And he said, David, I've been on methadone for 8 years. And I was shocked. I was like, what do you mean? And he said, I never tell anybody, because the first time I went to a meeting and talked about it, everybody there told me I wasn't clean and that I needed to just listen and sit on the side, not around the circle. He said, so I haven't told anybody since then. He said, but yeah, the truth is that's what helped me manage my recovery and not use heroin for the last 8 years. So, I mean, and this is a guy that chairs meetings and has kids and has his own construction company and, has been like a peewee football coach and a t-ball coach for his kids. I mean, he's an amazing dad, amazing father. And what really made me sad is he said, and I can't be honest about this with anybody, because if I was honest, I'd lose 3/4 of my friends, because 3/4 of my friends are from the program. So then I asked him the question we all ask, right? I said, so when are you going to get off your medication? when are you going to stop taking methadone? And he said, are you on any medication? And I said, yeah. He said, what are you on medication for? And I said, high cholesterol. He said, so how's your cholesterol level? I said, oh, the doctor said my cholesterol is fine. He said, my doctor told me the medication's working. And then I stopped. And I was like, okay, I see what you're saying there. You know what? You are prescribed medication, and that medication is working and allowing you to live a life in recovery. So for me, it was really eye-opening. But if you look at it as far as 12-step programs go, how many people are 12-step programs leaving out because of some people's attitude towards medication? And the sad thing is, it used to be this way about even mental health medication. Back in the day, people told you it didn't matter what kind of medication it was. If it was a behavioral health medication, that you weren't really, to use terminology that's used around the room, clean or sober if you were taking medication. But I have seen 12-step programs help so many people, and I think it could help so many more if some people got more educated on the effectiveness of medication and treatment. So, do you have anything to add there, Robert?
I think it's the same thing. I think that, I don't think I said this, but I am part of the 12-step community, and that is the program of recovery that I use. And I know for me, the shift happened. I was needing to do my internship, and I was talking to Ned Presnall at Clayton Behavioral, and I said, Ned, why don't you, if I'm gonna disagree with the use of medications to treat OUD, let me come over there and do my internship so I can really get educated on it. And so I got over there, and what happened was, first of all, they started providing me all the data, and they really ingrained into my brain. They said, we need to stop treating this with opinion. We need to treat this as a medical condition, and with medicine, we follow the data. We don't have a silver bullet to give somebody for addiction treatment. So we just have to follow the data on what's going to give them the best chance of survival. And that's what a lot of these slides right here are really showing. When we look at the data, it's a small percentage. But I think to take it one step further in my education over the years is it doesn't mean that the 12-step community can't still support this. It's just another tool in our tool belt is the use of medications. The bigger problem for me is when you have in the 12-step rooms, when we are not speaking up and talking to Joe the plumber, who's giving medical advice to his sponsees and telling them, you're not really sober or in recovery unless you go off the medications. And that became a big problem for me personally. I decided that within the 12-step community, I would find the groups where the group norm was. It wasn't stigmatized as in some groups, and just do a better education and start facilitating that change from within. And I know David works on that from his end as well. But the shift for me was really when we started looking at the data. And it wasn't to point out one way better than another. It was to follow the data and see how we could utilize everything. With the amount of deaths that we're seeing due to the poison drug supply of opioids right now, we don't have the luxury of not looking at alternatives from what we've always done, and I'm using quotation marks in the air right now. So that's just kind of my experience within the 12-step community and such. And, David pointed out something important too, is that, with mental health, with traditional mental health medications, say somebody that's on a medication for schizophrenia or bipolar, we're so quick to tell them, you're taking your medications every day, right? You're taking your medications every day. But then with somebody for the treatment of OUD that's on a medication, it's, well, when are you going to go off your medication? And that's another more of the stigma surrounding this, that we are trying to facilitate some change. So that's my narrative on that, you guys.
Okay, I think I got your next slide up, Robert.
Right. Waiting for it to change on my end, I guess. Yeah, I'm not seeing it on there, but there it is. The next slide up looks at stabilization on the medications. So when we look at buprenorphine and we can see the length of treatment episodes, again, this is following the data that's being provided, showing the relapse rates for buprenorphine, methadone. We see a stabilization with the use of these medications. There are other risk factors that can come into place. We know that barriers to access to these medications right now are really affecting. We don't have enough buprenorphine waiver doctors, access to those doctors, and it's something on the state level through the SOR grant that we're actively educating on to try to open that up. Next slide.
Yeah, I would just add, I mean, looking at that slide, we see stabilization with medication within the first couple months of being on medication. That takes 5 years of long-term recovery for somebody who doesn't use medication to attain.
That's a great point. The next slide talks about the mortality risk in and out of methadone treatment. You can see the numbers there. The people that are in treatment are about 11 to 12%. Out of treatment, where it jumps up to the 35 to 36% range. Again, following the data instead of our opinions. You know, one of the lines I know David uses all the time, and so do I. People don't recover if they're dead, and this data clearly shows the benefits of being on the medication. Next slide is the buprenorphine. Again, in treatment, about half of what people out of treatment, the mortality risk. So we see that opioid substitution treatment absolutely works. It reduces the mortality risk, it reduces the deaths, and it does sustain people. You know, one of the things that I talk a lot about is when we look at problematic drug use and the symptoms associated, the negative symptoms associated with it are interaction with the criminal justice system, unemployment, lack of family relationships. You know, they're not going to work. They're being arrested. They're not engaging with their family. And once we stabilize, we induct somebody onto the medications and get them involved in the 12-step community as well. We see that all of those, the problematic use symptoms, start to diminish and or completely go away. Now they're able to work. Now they're able to show up for court. They're not running from the police and the justice system. They're showing up for family events. Families are starting to talk to them because they're acting rational, right? That's something that we hear a lot about. And so following, again, I'm just going to keep repeating myself, and I apologize, but just following the data is so critical when we have a problem of this size. Next slide.
Absent retention and treatment?
No, I'm sorry, the retention and treatment. This was a very important slide because that is our goal. We know that retention and treatment directly affects outcome numbers. So we can see here that people that are provided just a 14-day detox, that their retention and treatment numbers are significantly lower. Not a little bit, they're significantly lower. And we have to remember that all these percentages are people's lives. And when we bring in 12-step bias of abstinence only, or you're not really sober, and I know we're about to get into some of those slides that David's going to talk about, but when we bring that in, we're discounting what the data provides us. And the data shows right here that 9-week maintenance provides much greater numbers than when we start people on a 14-day detox, because we want them to be, again, with my quotation marks that you guys can't see in the air, we want them to be sober. We want them to be off of all medications. Here's the past week opioid use. Go ahead. You can go back to that other one, David.
Yeah, it's going to bounce back a couple times. I thought you were going to go and you didn't. I was trying to read your mind and I failed.
Yeah. So here we go with the past week opioid use, the 14-day detox. We can see that the numbers are much greater on the 9-week maintenance. We see at the 12-week to 6-month, and it's an interesting slide because we see where, again, people are introduced to the thought that they need to start tapering. And as that thought comes in, it puts them at much greater risk, first of all, for an accidental drug poisoning if they return to use. But we see their numbers start to go back up whenever we introduce taper. So it's a very important slide that I hope all of you keep on your desk for a while and refer to it often so that we can, again, follow the data. Next slide. Okay, so for folks that are discontinuing the use of medications, the majority of them are involuntary. They are often discontinued from their medication for failing to abide by the strict program requirements. Here we go with you didn't show up for your appointment, so we're not going to provide you this life-saving medication. You didn't go to 3 groups this week, so we're not going to provide you this life-saving medication. And it's things like that are not necessarily helping our community. 1-month relapse rates following discontinuation exceed 50% in every single study that we look at. That's an astounding number. So the data shows that the longer the person is on this medication, that the better the outcomes, the long-term outcomes. And it goes back to the point of this was really utilizing the 12-step community and the medications in conjunction to provide the better outcomes. And I know on the next couple slides, if you want to switch over, David, the next slide is 170 Suboxone and the 12 steps, 173 people in office-based maintenance, Suboxone treatment followed for 6 months. There was no time limit on the use of their Suboxone. Suboxone and the 12 steps at 18%, 76% of the patients were on continuous Suboxone, and they were less likely to report using any substance, less likely to be using heroin, have damaging or close relationships. They are less likely to be doing regretful or impulsive things, hurting family, experiencing negative personality changes, failing to do the things expected of them. They were less likely to be taking foolish risks, being unhappy, and having money problems. Again, they were more likely to have an AA home group, and that's something that David and I are out there educating our 12-step communities on, is that we have an opportunity here to work with these people to actually engage them in the mutual support community, or the 12-step community. They were more likely to report having a home group, having a sponsor, attending 3+ 12-step meetings a week, to be employed at baseline, and also to be employed at the follow-up. And on the next slide, I just wanted to emphasize that people on the medication, while utilizing the 12-step mutual support community, they were more likely to have a home group, to have a sponsor, and still to be attending 3+ 12-step meetings a week. We see in the 12-step community, we've seen the growth of Heroin Anonymous. And Heroin Anonymous, the majority of those folks are offered medications. We've seen over the last 2 years a large percentage of that population starting to utilize the medications, because the group norm is that it was accepted within Heroin Anonymous. Not the same when you attend Narcotics Anonymous or Alcoholics Anonymous. It's not the group norm there. It's still, nothing from the neck up is what's taught. And so you don't see folks there utilizing the medications as much as in, say, HA.
Yeah, if I could piggyback really quick, Robert.
Yeah.
I mean, honestly, I think this slide right here is probably one of the most important slides that we have here, because we're talking about whether or not medication and 12 steps can support each other. And clearly, this study is showing that not only can they support each other, they can actually make attendance greater and make sponsorship greater and make meeting attendance greater whenever somebody's prescribed medication that has an opioid use disorder, compared to somebody who isn't prescribed medication that has an opioid use disorder.
Yep. All right. You want to go to the next slide?
Is it there?
Is the employed more likely to have been employed at baseline again? One of the measures that we're looking for, and employed at the follow-up as well, and that's over the 6-month study.
And before I get ready to kind of take over, I can piggyback on this one too. I did my grad school research project was over levels of burden, barriers, and supports that influence successful completion of family dependency treatment court. And I can tell you that we had one statistically significant indicator that somebody would successfully complete treatment court, and that was having at least a part-time job. So employment is extremely important to recovery. It gives people purpose. It gives people, it helps take up some of that time that might normally be spent doing nothing, romanticizing about old days and some of those things. And I thought we would kind of finish up by looking at some things that Bill W. had to say. I think it's important, him being the co-founder of Alcoholics Anonymous, and then also to look at some of the literature from AA and NA and see what they have to say. So here, Bill W. says, it must never be forgotten that the purpose of Alcoholics Anonymous is to sober up alcoholics. There's no religious or spiritual requirement for membership. No demands are made of anyone. An experience is offered which members may accept or reject. That's up to them, which is true. But I think right now there are demands that are made on some people that are going to the meetings. So he also had a few other things to say. I find that Bill Wilson was an extremely humble man. As he says, in all probability, we shall never be able to touch more than a fair fraction of the alcohol problem and all its ramifications. Upon therapy for the alcoholic himself, we surely have no monopoly. So he's saying, you know what, I know that we work, but I think we're only going to work for some of the people out there. So we need all of these other treatments and modalities and supports out there for people so that we're not just saving a small fraction of the people with alcohol problems. We're able to support a huge fraction, a huge percentage of the people that have alcohol problems. And with alcohol problems, you know, we look at all substance use problems now. Because as AA started off a place where people went who just had an alcohol problem, now people go there that don't even have alcohol problems, that they have other drugs of choice that they use, but they find that they found their recovery best through AA. He also says in no circumstances should members feel that Alcoholics Anonymous is the know-all and do-all of alcoholism. And then he says, then too, it would be a product of false pride to believe that Alcoholics Anonymous is a cure-all, even for alcoholism. So once again, he's recognizing that we're not going to be able to help everybody, even everybody that has an alcohol problem. Because as he says in the quote below, when you consider the ramifications of this disease, we've just scratched the surface. I think we should humbly remember that. And humility is always a huge piece. And as I always say, it's not humble to think that my way is the only way. And unfortunately, I think we've seen dogma that's kind of started to form as people come together. You see it not just in 12-step meetings and support groups. I mean, you see it in churches. You see it in many different organizations where when people come together, they come to they share a belief, and that shared belief over time, we'll read his quote. He says, it's a historical fact that practically all groupings of men and women tend to become more dogmatic. Their beliefs and practices harden and sometimes freeze. This is a natural and almost inevitable process, but dogma also has its liability. Simply because we have convictions that work well for us, it becomes very easy to assume that we have all the truth. This isn't good dogma, it's very bad dogma. It can be especially destructive for us of AA to indulge in this sort of thing. So he's saying, thinking that we know all the answers, and, you know, I think some of the slogans we use even back that up, right? Or whenever we talk about somebody who might not find success through a support group or even in treatment, what's one of the most popular things that people say? Well, I guess they just didn't want it bad enough. I guess they weren't ready. I'll give a little forgiveness to people who are in support groups because we have lay people in support groups. But when it comes to treatment, sometimes I think maybe we should be looking at ourselves in treatment and looking at the modalities we're using, looking at the therapeutic alliance, looking at motivational interviewing and some of those things, because maybe if they're not being successful, it's because of us. And maybe we shouldn't be blaming it on them. So AA has a pamphlet on. Go ahead.
I'm sorry, I didn't mean to interrupt you. I was just going to say, I think that the brilliance in not only that quote, but in the 12-step, in Bill Wilson and his setup of the 12-step community is that, and this is something that we can remind our clients, is that every group is autonomous. Meaning, if it is the group norm that there is a dogma or a stigma within that group against the use of medication, go to another group. Find a group where that isn't instilled in there, where it is more acceptable. And I remind my clients of that all the time when it comes up. That listen, you know, they talked about medications, great. Not every group is autonomous, and not every group is going to be that way. Let's go find another meeting. Let me suggest a couple to you that I know of. And we should be providing that reinforcement for our clients that there is acceptance, or maybe it is an HA thing, Heroin Anonymous, another 12-step community where it's more accepted. So I just wanted to add that was the brilliance is that they set this up that every group was autonomous. So every group's going to be facilitated. It's going to be facilitated in a different way. You're going to have different readings. You're going to have different group formats, group norms, things like that. So, sorry, David, I just wanted to jump in there with that and support what that quote's.
I think that's a great point. And I think I also don't think we've mentioned like MARA and some of the other 12-step groups that are out there, because now there's Medicated Assisted Recovery Anonymous. So, I mean, they're starting because some of the groups weren't as accepting. They've actually started 12-step groups that are primarily for people who are prescribed medications so that they have a safe place. So in the AA member medication and other drugs, it says no AA member should play doctor. All medical advice and treatment should come from a qualified physician. I think that kind of goes along with something Robert said earlier, where we have Joe the plumber who decides he's going to tell somebody what medication they should or shouldn't take. And there's absolutely no reason somebody should be playing doctor in the rooms. It also says because of the difficulties that many alcoholics have with drugs, some members have taken the position that no one in AA should take any medication. While this position has undoubtedly prevented relapses for some, it has meant disaster for others. And we've got a couple more. Unfortunately, by following a layperson's advice, the sufferers find that their condition can return with all their previous intensity. On top of that, they feel guilty because they're convinced that AA is against pills. It becomes clear that just as it is wrong to enable or support any alcoholic to become re-addicted to any drug, it is equally wrong to deprive any alcoholic of medication which can alleviate or control other disabling physical and or emotional problems. So basically, this is saying that we don't have that right. And I know I've seen it. I know two mothers who have lost their kids because their kids started going to meetings and they ended up getting a sponsor, and that sponsor said, well, you know what, if I'm going to work with you, you need to stop taking your medication. And within a week of them stopping to take their medication, one of them had 6 months. And within a week of discontinuing his medication, he was dead from an overdose. I'm sure, Robert, you've seen that in St. Louis too.
I have 6 names I could rattle off of that exact same scenario. They were told that they weren't sober as long as they continued on their medications, and when they discontinued their use of their OUD medications, they were dead within a week. 6 names.
So Narcotics Anonymous has a pamphlet that is for persons receiving medicated assisted treatment, but it's more for professionals and other people. This pamphlet is, and in it they say and this echoes what Robert said earlier about different meetings having their own group think, and because they're autonomous, different groups are run differently. So when it comes to long-term maintenance, it might be important to find out which groups in your community are medication friendly and which aren't. Because this says, we understand that addicts whose path is medically assisted treatment may hear many messages in NA meetings. Some NA meetings make no distinction as to whether those receiving medication to treat addiction may share in a meeting, while other NA meetings limit the participation of those who are taking this type of medication. Each group is free to make its own decision on recovery meeting participation and involvement in group services for those receiving medication assistance for drug addiction. So this basically says, listen, because you're a group, you have the ability to say. And because of that, there's definitely going to be some groups that are more medication friendly than others in our communities. And once again, I think of the saying that the newcomer is the most important person at a meeting. But I also think sometimes we have the ability to alienate people with some of the messages and attitudes we have. And in NA groups and medication, it kind of echoes that when it says, if a group has an unwelcoming attitude towards new members who take medication for a medical condition, that group will likely alienate the very people it's trying to introduce to the NA message. And if you truly believe that that message is a life-saving message, why would you possibly want to alienate the very people who probably need to hear it the worst?
Yeah,
Once again,
I think that, sorry, I was just going to add something that I always try to remind our 12-step community is, Alcoholics Anonymous was founded on some harm reduction principles. We're quick to tell the newcomer that comes in, hey, keep coming back, even if you're drinking, right? Even if you're still drinking, just keep coming back. But somebody that comes in that announces that they're on medication, that the stigma is there, and we tell them that it's told to them, you're not really sober until you get off that. You can come, but you're not really sober, and it's two different messages. And the messaging, the stigma provides the shame that the active user needs to regress back into their active addiction. And that's something, within the 12-step community, I know David's doing it, we're doing it here a lot more, is trying to show the positive to engaging that individual. Yeah, you're on medications? Absolutely, and go back to the study on the 6-month study, it shows that those people on medications are more likely to get a home group, more likely to get a sponsor, more likely to attend 3+ meetings a week. So I just wanted to make that point that, Alcoholics Anonymous was founded on telling people, inviting that newcomer in and just supporting what you were just saying, David. That's all I wanted to add.
Thank you. Because like you said earlier, dead people never find recovery. So it should be our mission to help people stay healthy and alive long enough for that message to work in them. So I'm just going to kind of hit some highlights on the next couple quotes. Like the next one, it says groups should exercise judgment in deciding if a member is able to perform the task associated with the service position, not whether or not that member is taking medication. So the important part is, can they do the service position, not are they taking medication, because that rules them out. And the next one, it just says that when it comes to those who participate in drug replacement, it's helpful to remember that our third tradition clearly states that membership in an NA is established when someone has a desire to stop using, or when they choose to become a member, not when they are clean. So no matter what the issue, groups are still charged with the goal of welcoming each person who walks into a meeting. And on the next one, it says, we have to, even though NA is a program of complete abstinence, we should ensure the clarity of the NA message, but we also need to balance that, because the idea that membership in AA comes with the desire to stop using, not abstinence. So I can't sit there and really ridicule somebody. In fact, kind of like what Robert said, it's amazing how we circle around people and support people that have a recurrence of use with heroin or methamphetamine or alcohol. Yet when they're on medication and they're doing really well, sometimes it almost seems like we push them away. And finally, the next one says that the reality is some groups already permit people who are prescribed medication to share and lead meetings, because the only requirement for membership is the desire to stop using. So even though many people have a really strong personal feeling about medication, the group isn't there to enforce, endorse, or oppose members' personal opinions. And medication is a personal opinion, how a lot of people feel about that inside the rooms. So we have a responsibility not to represent our personal feelings and opinions as the opinions of NA as a whole. And as you can tell, NA as a whole says each group is autonomous, and that if they want to allow people to engage in service work and to chair meetings and set up tables, make coffee, and some of those other things, that's on the group. So, Robert, do you kind of want to take over here?
Yeah, real quick. I want to make sure that it's understood that our tone here isn't to point out what 12-step communities are doing wrong. And because that's not, David and that's not our goal here. Our goal here is to say that we can support people with the use of medications. You know, as a member of the 12-step community, it's my purpose to share my experience, strength, and hope. My personal experience is that abstinence worked for me. And I can share that experience with people that are seeking that path. But I would also like within our 12-step community to be able to, if a person is using medications that I didn't use, is to be able to point them out to somebody that is engaged in the 12-step community that is on medications and let them seek out their experience, strength, and hope. And so I just want to make it clear to all of you that the point of this slide set wasn't to say AA is doing this wrong or AA should be doing that. It's that there has been this dogma created, and what it's doing right now, based upon this slide that David has up right now, is it's fueling this even further. There's so many people out there that we could better reach if we integrated medications and the 12-step community. So the next slide after the death rate is the France buprenorphine initiative. I'm sure a lot of you have heard about this, but basically what France did was they removed all barriers. You know, we have so many barriers right now to the use of these medications, whether it's FQHCs or the barriers to even going to a methadone clinic. For some of our clients, just getting access to it or getting the $12 a day that it costs to go down and dose can be a barrier. The other, for buprenorphine, finding a waiver doctor. You know, one of the questions that was sent over to us is, how do you suggest we provide long-term maintenance to clients with limited waivered physicians in the area? And looking at how we can overcome these barriers. You know, my answer to that was we need to look at utilizing telehealth services in a lot more of the rural communities. I mean, my goal is to really get more primary care physicians to move a lot of this treatment into the primary care physician locations where you don't have to seek out a waiver doctor that are spread across the state, that all of our primary care physicians can prescribe buprenorphine for the treatment of OUD. The waiver is a barrier that hopefully they'll do something about soon. I know there's talk of it, but the next slide.
The next two slides didn't come over very well. It only shows a piece of them.
Okay, but back to the France real quick. The France buprenorphine initiative, basically they removed all barriers. They said anybody can prescribe it. Anybody can come in and get it. We're going to provide it. We're just going to flood, right? We're going to flood buprenorphine because we know that it reduces mortality risk. And I believe it was within 4 years of doing that, of removing all barriers, that their death rate dropped in their country by 83%. And that's a staggering number. Can you imagine if we had greater access to buprenorphine and how well we could drop our numbers? The Know Your Rights pages, and I'll just read a couple of them, it really surrounds the other challenges that we have in the recovery community, recovery supportive housing. So the Oxford model, you couldn't be on any medications to come into the houses. And there's certain houses now that are operating autonomously. More recovery supportive housing have spread throughout the state. As mentioned earlier, I own and operate 5 here in the St. Louis area. And that was the first thing we did when we set up the model. We said, no, yes, you can have medication. You can be on medications. And we're going to support you in that process. And so the again, looking at new ways to remove the barriers to these things. Housing and MAT, housing discrimination related to medication-assisted treatment sometimes arises in the context of residences for individuals in recovery. Individuals who live or want to live in halfway houses, recovery homes, or other residences for individuals in recovery are sometimes excluded because of their participation in MAT. It's illegal, even though this type of discrimination occurs with some frequency. The FHA applies to residences such as recovery houses because they fall under the FHA's definition of a dwelling. Individuals in MAT are protected by the FHA. They are also protected by the American Disabilities Act if the resident receives state or local government funding, and by the Rehabilitation Act if the resident receives federal financial assistance. Accordingly, these residences may neither categorically exclude people in MAT nor insist that they abstain. But this is what had been happening, and it is regional to some degree. All right, I'm going to skip down to the takeaways in the appreciation of our time here. A program can have high standards without discriminating against persons who receive medical treatment. And that can be our 12-step community program. You know, I've seen people that have come up to me that have engaged in the 12-step community, albeit most of the time quietly while on their medication, that have sponsors, have regained their lives. I've hired people to work in the treatment field that are on their medications. It can't be a reason for discrimination of employment. Again, illegal. You know, we need to treat individuals that may or may not use medications just like we would treat anybody else. And that's my final takeaway. David, what do you have?
I would just say really quick, because I know we're out of time. I would kind of echo what the NA literature had said, that it's not about whether or not somebody's on medication. It's about whether or not that person can perform the functions that are needed for whatever they're applying for. And also to remember that if the newcomer is the most important person there, we should support them regardless of whether they are prescribed medication, whether they are going to treatment, whether they are living in a recovery residence, or whether they have recently used heroin. You know, so I think by being more supportive, the 12-step recovery support groups have an even better, a bigger ability to positively impact people and to grow the ranks of people who are living amazing lives in recovery.
Awesome.
And that's it.
Thanks, everybody.
Yes, thank you both, Robert and David, for that presentation, and thank you all for joining us today. And have a great weekend.